Zillow, and I'm the Executive Director of the New England Hemophilia Association. If I haven't met you yet, it's great to meet you virtually over Zoom for tonight's presentation. This presentation will be recorded. If you do not want your video to be on, you can simply turn that off, but this presentation will be recorded this evening. Based on a community needs assessment from 4 years ago, the Consumer Medical Symposium was created to help you better understand current and potential medical advancements. This event was scheduled originally for March 28th in Rocky Hill, Connecticut, due to COVID-19. Since the educational content from this event is vital for our community, we have moved it to this interactional virtual series for the next month. This event starts this evening and goes until August 8th. It will include weekly Wednesday webinars starting tonight. It will have a live event on Saturday, July 25th, which you will learn more about, an exhibit hall, and a scavenger hunt, which we hope everyone will participate in. Thank you to the Consumer Medical Planning Committee. If you are on the planning committee, just give me a wave. You guys have been through quite a bit to kind of help us out and think of this virtually, and thank you for your service. We also want to say thank you to our sponsors. This event would not be possible without the support from so many companies. I know this is not the same of going to a hotel and having exhibit space, but we thank you for the support that you give to NEHA. So I just want to thank these companies. So our presenting sponsors, and as I call your name, if you could just wave too, if you're on tonight: Bayer, BioMarin, CSL Behring, Genentech, Octapharma, Novo Nordisk, Singalong Therapeutics, Spark Therapeutics, Takeda, and Tremo Pharmaceuticals. Thank you for the support that you give to NEHA. Our champion sponsor is Sanofi Genzyme. Thank you. And our advocate sponsors: Accredo, Biomatrix, Cottrell's, CVS Health, Diplomat, Drugco, Grifols, Medaxis, I always get that one a little bit tongue-tied, but I'll work on that, Paragon, Pfizer, and Superior Biologics. Thank you so much for the support that you give to NEHA. I'm going to stop sharing my screen now and talk a little bit about tonight's webinar. So the first of the series, these are our keynote presentations that we were going to have in person, is called The Shifting Paradigms of Hemophilia Treatment. And our speaker is the one and only Cathy Rosenfield. Cathy is a pediatric hematologist and the co-director and an associate clinical professor at the Tufts University School of Medicine Hematology. She has been practicing since 1980, was on the NEHA board of directors in the early 2000s. And according to Cathy, and I think she summarized this beautifully, her career boils down to 3 points: family, patients, and education. So before we turn it over to Cathy, we're going to do a couple of polls. For those that have been on NEHA events before, we do live polling. So if you have your phone handy, you're going to need it for this. So I'm going to share my screen again. Just give me one moment here. All right, so we want to know, and we're going to start off with, what is a good or bad habit that you started over the last 4 months? This is all anonymous. We are not going to track this. It's just a way to kick this event off. So what you're going to do is you're going to text 781-412-7971 with your answers. So we have walking every day. Let's see. Flossing more. I like that. I'll let this binge watching, Netflix junkie. I totally hear you on that one. Sleeping better. Drinking wine. Nice. Hot fudge sundaes a lot. Whoever said that, I'm going to come over your house tonight and eat one after this. Gardening. Let's see if we could see some of these others that are exercising is coming up quite a bit. Biking, sleeping better. Lots of Zooms, yes, lots of Zooms, and reading. So when you see words that are getting a little bit larger than this, it means that people are saying it more than once. Talking to my spouse, kudos. If I had a hat on, I would tip it to you for whoever put that on there. So we're going to go on to the next question. The next question is, if you're taking a vacation or road trip this summer, I know many have postponed that. I know these are still coming in from the last one. So where are you going? So living room, Maine, the Cape. You just get a text again, 781-412-7971. Cape Cod is coming up quite a bit. Finger Lakes, Villa de Kitchen. I like that one. We have Plymouth, Mass, Home, Rhode Island, White Mountains. It sounds like most people are staying here in New England, which is what we expected, or going to upstate New York. Do love the Jersey Shore and the living room are two of my favorites. We do have someone going to Puerto Rico. Maybe you and Villa de Kitchen can go together and cook some good food there. So now we're going to transition into questions for tonight. As we talked about, this is the paradigms of hemophilia treatment. So the question is, for those on the phone, I have a strong understanding of emerging therapies that are currently being tested in clinical trials. Text 1 to strongly agree, text 2 to agree, text 3 if you're neutral, text 4 if you disagree, and text 5 if you strongly disagree. So we'll give this a moment here. And right now, for those on the phone, we have 43% say that they agree that they have a good understanding of the clinical trials, but in a close second, we have strongly disagree. So it's pretty much, first place is folks agree, second is strongly disagree, and then pretty much everything is in the middle there. And this just gives a good background of where we are before we begin tonight's presentation. The next question is, I am comfortable talking about clinical trials with my provider. Strongly agree, agree, neutral, disagree, strongly disagree. And if you don't know quite where you are, just kind of pick one that you feel. So for those on the phone, strongly agree is at 59% right now, followed by disagree at 16%. And we're fluctuating a little bit, but I think this is strongly agree is a good sign because that shows a good relationship with your provider. Last question before we turn it over to Cathy. What is one thing you hope to take away from tonight's session? If you're a patient, if you're a provider, if you work for an industry, or if you're a friend of someone, just one thing that you are hoping for that you could take away from this session. And I'll read them out loud as they start coming in. Guidance, new info, knowledge, learn something new, understanding, better understanding of my possible treatments, learn something new, better understanding, interesting new therapies, will gene therapy actually happen? So this gives us a good idea of kind of where we all are. So with that said, it is my honor to kick it off and turn it over to Cathy Rosenfield. So Cathy, I'm going to have you share your screen now.
Okay, and hopefully I can do this correctly. I want to thank Rich and Neha for inviting me to talk with everybody tonight, and I want to thank everybody who is spending their evening with us for doing so. I'm just moving this out of the way. Okay, so I hope tonight there's not enough time in one session to go into great depth with regards to everything. So I really planned this as more of touching on various aspects of treatment for hemophilia and giving a broader overview. And then hopefully by answering questions, I can key in on more specific issues if we have time. This gives you my disclosures, and the only one I really want to say is I do talk very fast, and I apologize for that. I try to slow down, but sometimes I forget. So the objectives for tonight are to look back at where we have been, to look back on the history of hemophilia a little bit, because I think it's important to know where we've been to really understand where we are and where we're going. I will give a review of the products that are listed here. And the last thing that I'm going to talk about is is the concept of patient or parent voice in choice. That is, as an individual either choosing for your child or choosing for yourself, it's very important for you to be able to make a discussion, have a discussion with your providers. The history of hemophilia goes way back to the 2nd century. The first writings that we found were in the Jewish scriptures, the Talmud, and they recognized that there was a male-specific bleeding disorder to the extent that if a family had 2 sons who died from bleeding related to circumcision, they did not have to circumcise subsequent sons. And then in the 10th century, one of the first actual writings by a surgeon described a tribal village where many males died from bleeding related to injury. Between medieval and Renaissance times, so that's the 5th to the 15th century or so, there were other scattered reports of males with severe lifelong bleeding. And then we fast forward all the way up to the 1800s, when John Otto reported a family with bleeding, and that really piqued the interest in the medical community to further look at this. In 1820, Mass wrote the first complete medical review of hemophilia, and Hopp actually gave it a name using a Greek word which meant blood-loving. In 1893, it was demonstrated that blood obtained from somebody with hemophilia was actually very slow to clot in the test tube, which suggested that there was a clotting defect. And in 1905, how blood clots was first attributed to a variety of different factors, and Morowitz thought he identified the factor that was deficient and termed it tissue factor. He was a little bit off, but along the right idea. And it wasn't until the 1930s that Patek and Taylor took blood from healthy individuals and showed that they could isolate a fraction of it, mix it with blood from individuals who had a bleeding disorder, and correct the disorder in the test tube. In the early 1900s, Bateson first described the genetics associated with this, and he identified it correctly as a sex-linked disorder, recognizing that women appeared to carry the gene but passed it on to male sons, male relatives. And then in 1911, an enormous report was written consisting of 1,000 cases from over 200 families, which demonstrated that within a given family, there was consistency with regards to the severity of bleeding, but the severity could differ from family to family. The most famous family is the royal family, and Queen Victoria in the mid-1800s was identified as a carrier of the gene, and this pedigree nicely shows how she had several children affected. She had 2 daughters who inherited the gene, and she had 1 son who had the disorder. And when you look at this pedigree, the green squares are males who had hemophilia, and the circles that are half green are women who carried the gene. The most famous of the families was the Russian family, the Russian royal family, Nicholas and Alexandra, who had a son, Alexei, who was afflicted with hemophilia. And one of the most famous treaters of this child was Rasputin, and we'll talk about him in a second. It wasn't until the 1950s, so we've gone from the 2nd century to the 1950s, that they actually recognized that there were 2 different forms of hemophilia, and they termed them hemophilia A and B. And in the mid-60s, an international conference convened and named the factors, factor 8 and factor 9. And this was somewhat based upon the fact that they had begun to identify how blood actually clots. And it does clot via a cascade of activation of proteins that then go on to amplify other proteins that eventually gets the clot to form. And they began to understand better how factor 8 and factor 9 played a role in getting blood to clot. So where does the treatment fit into this? Back in the 2nd century, the only way they had of treating was prevention. So they prevented bleeding from occurring by not circumcising. And I would imagine they prevented bleeding from occurring by avoiding injuries that could cause bleeding. But it wasn't until the mid-1800s that they actually looked at treatments. And they used blood transfusion. They recognized that if you gave blood from somebody who didn't bleed to somebody who did, you could get the bleeding to stop. Now, what they didn't know about was the fact that you can't transfuse incompatible blood types because that hadn't been elucidated yet. So some of the reactions from these blood transfusions were in fact life-threatening, but the bleeding stopped. Rasputin in the early 1900s actually played a role in the treatment of Alexei, who had hemophilia. And there were two interesting things about this man, who was called the Mad Monk because he was a tad crazy. He recognized that, number one, medication could make Alexei's bleeding worse. And he insisted that they stop giving Alexei aspirin for pain, because aspirin affects, he didn't know this, but we know that aspirin affects platelets, which are crucial cells for preventing bruising and bleeding. And if you interfere with their function, it will make the bleeding much worse. He also recognized that hypnosis could help Alexei deal with the pain that he had associated with his bleeding symptoms. And this was really the start, or the beginning of complementary or alternative approaches to treating pain, which has taken us almost 100 years to really incorporate into our treatment of individuals who have pain associated with bleeding joints. And those include things like acupuncture or acupressure, relaxation techniques, hypnosis, massage. I think it's also important to recognize too that there are many other over-the-counter or herbal medicines which are similar to the way aspirin affects bleeding and can potentiate bleeding in somebody that already has an underlying bleeding disorder. The next big step in terms of treatment didn't come until the 40s, and it was actually related to World War II and the need for blood products on the battlefield for treating injuries. And at that time, separation of blood component therapy, was developed. So they would take a unit of blood that was collected and use centrifugation techniques, to separate out the components of blood into the cellular components of blood cells and platelets, and then the plasma. And plasma contained all of the coagulation factors. And for the first time, we had something besides whole blood to treat individuals with hemophilia. Plasma contains factor VIII and factor IX, as well as all of the other coagulation factors. And so in a much smaller volume, you could give a much more effective treatment for somebody who was bleeding. Now, plasma did have its drawbacks. It was still a large volume to give to individuals, and particularly to children, and volume overload, which could affect breathing and affect blood pressure, certainly was a problem. But nonetheless, it went a long way in terms of stopping bleeding. Due to shortages of human blood, other sources of blood were tried, such as pig and cow blood, which also contained factor VIII and factor IX. And despite horrendous reactions to the product, actually worked in terms of stopping bleeding. In the mid-60s, Judith Graham Poole further developed a product from plasma that contained factor VIII called cryoprecipitate. She took frozen plasma, quickly thawed it, and the first product to come out at the top of the plasma was a concentrate that contains factor VIII, fibrinogen, factor 13, and it could be used for treating patients with factor VIII deficiency. And in a very small volume, get the same amount of factor VIII that you would get in the much larger volume of plasma. And then in the 70s, desmopressin, or DDAVP, which is a medication, was found to increase circulating levels of factor VIII. Now, you have to make some factor VIII for this particular product to work, but in individuals with mild factor VIII deficiency, 10, 15, 20% of factor VIII, it could increase their circulating level of factor VIII 2, 3, 4-fold, and could be used for treating bleeds, and it was not derived from blood or plasma. But the big evolution in treatments came in the 70s, late 60s, early 70s, when plasma-derived concentrates were made. And that was when they were able to take from plasma factor 8 or factor 9, prepare it as a lyophilized product in a powder, in a vial that could be administered at home in a very small volume. And this was an amazing development. The benefits of this allowed for very rapid treatment at home, for prevention or treatment of bleeds. It made individuals autonomous. They no longer had to trek into the hospital or the ER or the clinic to get treated. And it gave larger volumes or larger amounts of factor 8 or factor 9, but in a very small volume. Everyone is exceedingly excited about this. However, the risks associated with this became evident over time. These products were made from thousands of donors. And at that time, donors weren't screened the way they are now, nor were these products in any way purified. And pretty much you were assured of developing hepatitis, which at the time we knew about hepatitis A and B. We hadn't yet recognized hepatitis C. It was called non-A, non-B. Hepatitis C itself wasn't recognized until the 90s, but everyone developed hepatitis. Now, early on, the risks felt to be outweighed by the benefits. People still felt that the availability of this product, the rapid treatment associated with this product outweighed the disadvantages of hepatitis. But by the late 70s, early 80s, it became obvious that there was another virus that was within the blood supply, and that was HIV, which quickly became known to be not just problematic, but life-threatening. And many individuals with hemophilia became infected with HIV. This led to looking for safer ways of delivering the same types of concentrates. And it led to purification techniques. In the early to mid 80s, companies went on to use viral attenuation processes with heat pasteurization treatments, solvent detergent treatments, and filtration treatments to eliminate hepatitis A, hepatitis B, hepatitis C, HIV, parvovirus, and a variety of viruses. In addition, the concentrates were purified further to eliminate all of the other extraneous proteins that were present and to narrow down only the presence of factor 9 or factor 8 with its complementary protein, 1 Willebrand's protein. And these purification processes went a long way to making these concentrates safer. The other thing that happened in the 80s was that the factor 9 and factor 8 genes were cloned. We identified the sequence of amino acids that developed these genes. And that led to the ability to make recombinant, genetically engineered concentrates that were no longer plasma derived. These were developed in cell culture, in the lab, and brought us away from worrying about safety from viruses. These went through a number of different iterations. The first generation, second generation, and third generation products refer to ongoing purification of these concentrates with regards to the use of albumin, both bovine and human albumin. But this started in the early 90s and was another major step in providing safer and effective treatments. The other thing that happened in the 90s, once the gene had been cloned, was the start of gene therapy trials. And although it's taken us a long time to get to the point that these are now actually very active in clinical trials and really on the horizon, this is when they started. And the last big step forward was the development of prophylaxis. Before the 90s, we did not routinely infuse to prevent bleeds. We treated on demand. You bled, you treated. And in the 90s, Marilyn Mako Johnson did a seminal trial where she looked at the efficacy of treating prophylactically, infusing every other day or 3 times a week, and the impact that that had on bleeding episodes, joint bleeds, muscle bleeds, and the quality of life. And we found quite clearly that prophylactic treatment was a far better way to go, and in the long run was less expensive because of the decrease in joint disease and the increase in quality of life and the ability to go to school on a regular basis or to go to work on a regular basis far outweighed the treating on demand. More recently, from about 2010 on, further modifications of the recombinant products have happened. The development of extended half-life products, trying to modify the recombinant products so that they last longer. And modification of the products have occurred with something called pegylation or fusion with proteins such as albumin or immunoglobulin. And it's meant to affect the metabolism and the breakdown of factor 8 or factor 9 so that it lasts longer and results in fewer infusions and achieves better factor levels overall, avoiding the peaks and the troughs a little bit. From 2015 on, we've seen even more novel treatments. Gene therapy really has begun to take off, and hemostatic agents that are not factor products, so not factor 8, not factor 9, have become available. Emicizumab, Hemlibra, and then other clinical trials that are ongoing. I'm going to start now, since we've gone through the history, to talk more about the specific concentrates and the products that we have available. There are still plasma-derived concentrates available. The safety of these concentrates depend upon two things: decreasing the viral plasma load and viral inactivation. And in order to decrease the viral plasma load, you need to rely on donor selection, asking people not to donate if they have had hepatitis or have been in a high-risk category of people who might have hepatitis, as well as testing of the products to make sure that there are no detectable viruses in the product. And then to take it a step further with viral inactivation of the plasma that's being used: heat pasteurization, solvent detergent inactivation, and nanofiltration. These have led to products that we do feel are very safe to use despite being plasma-derived. And I've listed here the various factor 8 and factor 9 products that are still available. There are definite uses for the factor 8 plasma-derived products, as evidenced by the issue of whether or not they are better in terms of preventing inhibitor development. I've listed here as well FIBA, and I put FIBA under both factor 8 and factor 9 because we do use FIBA in individuals who have inhibitors. And FIBA is another one of these plasma-derived products. There are a large number of recombinant products, and there's been an explosion in the last 20 years of a variety of recombinant products, both factor 8 and 9. And I've listed all of them here. And I do want to mention that recombinate was one of the first generation recombinant factor 8 products. And there are still people who are very happy with recombinate and still using recombinate despite the development of all of these other products. I've also listed factor 7. And there are 2 recombinant factor 7 products available. And again, because we use these in inhibitor patients, Novo-7 and recently FDA approved 7-Fact. I have Epstyla listed down here as these are all short acting or standard acting recombinant products. And I listed the Epstyla down here, even though its half-life appears to be a little bit longer than the other recombinant products. But I've done that because it's not protein modified in any way. It doesn't have a modification to it in terms of the other extended half-life products. So the extended half-life products, which are listed here, are based upon adding a protein to the factor, modifying it in such a way that you either increase the amount of time that it circulates in the plasma or you impact on its clearance from the plasma. And the 3 processes that are listed here: pegylation, which refers to the addition of polyethylene glycol molecule to the product, or FC fusion, which refers to addition of an immunoglobulin to the product, and lastly, albumin. All of those can change the metabolism and allow the factor 8 or factor 9 to last longer in terms of its half-life. Now, we typically think of factor 8 as lasting about 8 to 12 hours for its half-life, meaning that within 8 to 12 hours, it's decreased in half in terms of its concentration, versus factor 9, which lasts about 24 hours. By adding these proteins, by doing a process to extend the half-life, factor 9's half-life has been extended significantly, 4 to 6 times what it was previously. We haven't been quite as successful with the factor 8 products. Their half-life may have been extended by 1.5 to 1.7 times the other products. And that actually is due to the fact that factor 8 circulates with a stabilizing protein called the von Willebrand's protein. And so the half-life of factor 8 is also dependent upon the half-life of the von Willebrand's protein, which is only about 15 hours. So it's hard with what we have available right now to extend the half-life of the factor 8 the way we have with factor 9. But they are working on that. All right. I'm going to move on to some of the newer hemostatic agents, the non-factor agents. And these can be divided into 2 types, those that enhance coagulation. And the one that is FDA approved is emicizumab or Hemophilia. This makes coagulation better. It helps the blood to clot. And this is not a factor 8 or factor 9, and this is only for factor 8 deficient patients. But it's a creative genius, I have to say. And I'm always in awe of the people who think of this and then actually develop these kinds of proteins. So this is a bispecific antibody, and this cartoon shows factor 8's function is to bring activated factor 9 in contact with factor 10, and it forms a complex. And this complex then goes on to activate other coagulation factors to generate thrombin, which plays a crucial role in getting blood to clot. What emicizumab does is it's a protein, and anything that has mab at the end of it stands for monoclonal antibody. It's a protein. It has 2 legs to it. One attaches to the recombinant factor, the activated factor 9, and it brings it in contact with factor 10, and basically it forms a 9-10 complex, which goes on to activate other coagulation factors to generate thrombin to form a clot. So it does what 8 is supposed to do, and it works nicely in doing that. Other hemostatic agents, non-factor products that are in development, actually look at rebalancing coagulation. And what I mean by that is we make proteins to help us clot. We make proteins to prevent us from clotting too much. And they're balanced. For most of us, they're balanced. So you don't bleed too much and you don't clot too much. We know that there are families that have alterations in this. We have families that have mutations that result in a deficiency of factor 8 or factor 9, and therefore they're a little unbalanced and they bleed too much. We know that we have families that have alterations in naturally occurring inhibitors that regulate clotting, antithrombin 3, protein C, protein S, and these individuals clot too much. These agents look at trying to pull things back into balance by affecting the clotting regulation. So right now in clinical trials, there's an agent called fitzerin, which interferes with antithrombin 3, which is a natural regulator of clotting. It's supposed to prevent too much clotting, but by inhibiting it, it allows clotting to continue. It allows thrombin to continue to be generated, and it allows people to clot, even if they're deficient in factor 8 or factor 9. And it seems to work. Also in development right now are anti-TFPI or tissue factor pathway inhibitors, again, a naturally occurring regulator of clotting, concizumab and marxizumab, again, mab meaning a monoclonal antibody, and it prevents TFPI from preventing clotting. So people continue to make thrombin and continue to clot. Now, if you think about this for a little bit, the concern here would be regulating this so people don't clot inappropriately or develop what's called pathologic clotting or thrombosis, strokes, heart attacks, deep vein thrombosis. And that's the potential limiting factor to these agents. But this is what they're sorting through right now. Another novel way of approaching hemophilia is gene therapy. And as I mentioned earlier, this goes back to the 1990s, but it's been a while in the works and sorting through the kinks that have been found along the way. But factor 8 and factor 9 are tremendous disorders for doing this because they're monogenic. They have very specific gene mutations, and there's only one gene that you have to worry about. And also, even a small increase in circulating factor can make a huge difference in terms of quality of life and clinical outcomes. So these began in the 1990s. The clinical problems that have been encountered involve the best way to insert the gene into somebody, the best vector to use, how to maintain expression of the gene. So you create the healthy gene, you find a way to put it into somebody who is missing the gene, but how do you maintain expression of it? How do you maintain adequate factor levels? The gene may still be there, but if the factor levels drop off, it doesn't work as well. And then identifying the long-term issues. And some of those are still unknown. Do we need to worry about other hematologic problems? Do we need to worry about oncologic cancer development from doing this type of a process? Do we need to worry about infectious issues associated with using viral vectors for insertion of the gene? So these things are still being sorted through and clearly are being watched quite closely. But we'll continue to need ongoing studies in order to delineate whether those issues are going to be a problem. This cartoon shows two types of gene therapy in terms of the kinds of vectors they're using. This one is called direct therapy on this side of the screen. It takes the missing gene, the factor 8 or the factor 9. They take a viral vector, and what they're using most often is an adeno-assisted virus, and they take out the machinery within the virus so it no longer works as a pure virus, and insert the missing gene. And then they magnify this so that they have a much more of it, and it's directly infused into the individual. Another way of doing this is cell-based delivery, where they take the patient's own stem cells. They again take a vector and put the gene that they want to replace into the vector. And in cell culture, they mix the patient's stem cells with this viral vector to allow the virus to incorporate it into the patient's stem cells, which are then infused back into the patient. So those are two potential ways of delivering gene therapy. And there's another way called cell therapy, and I took this off the web because I wanted to really better delineate how it is. And Sigilon is developing this. And what their premise is, let's make some human allogeneic cells that we can keep on the shelf. We don't have to make it specific to one individual. We can use these cells for anybody and modify them to express the gene that we are interested in, and then put them into a vector that is basically an immune shielding, has an immune shielding matrix to prevent it from being attacked by the patient's immune system, and then multiply this so that you've got thousands of these cells and put them in a place that is somewhat protected from immunosuppression, such as the abdomen, and allow it to secrete the gene that you've created to increase the factor level or to produce the hormone that you want, which again is a very novel way of approaching a type of gene therapy. All right. There are dozens and dozens of clinical trials out there, not all of which are active at the moment, but are in the process or have been looked at, or are finishing some of their trials. And the best place to explore these is at the website www.clinicaltrials.gov. This is a tremendous website. You go, you search for what you're looking for, you plug in the keywords gene therapy, hemophilia A, and every trial that is out there will come up, or gene therapy, hemophilia B. And you can look at what is available, what is actively recruiting, what has been finished, what has been stopped. The ones that I've listed here are the ones that are more in the news right now. And BioMarin, with their AAV vector, is very much in the news because they are hoping to get an FDA decision on whether this trial will actually become clinically available. And the FDA is supposed to decide by late summer. Expression Therapeutics is starting a trial at Emory University. And then Pfizer, in conjunction with Sangamo, are also looking at a potential trial. There are a number of companies that are doing gene therapy trials for factor IX deficiency. And at the ISTH meetings this summer, they're going to be reporting on the results of a trial that has been ongoing in Europe, using a really novel approach with a gain of function gene for factor IX that increases the production of factor IX. And that's going to be presented this summer. This cartoon summarizes everything that we just discussed. It shows that back in the early 90s, late 60s and early 70s, with the development of plasma-derived clotting factors, that went on into the 90s with the development of recombinant clotting factors, on into the 2000s with the extended half-life modification of the recombinant clotting factors, and then the investigational therapies with gene therapy and other novel agents. And what I really want to point out here is people recognize that individuals had a bleeding disorder back in the 2nd century. But in the last 20 years, we've had an explosion of products available for treatment for individuals with bleeding disorders. And it is amazing, I think, in how such a short period of time, we have seen such a rapid progression in what's available. The good and the bad of that is that we now have lots of treatment options. And the bad is, how do you decide which one to use? It sometimes can be overwhelming. Which brings me to treatment choice. And how do you go about deciding what you're going to choose? Some of that is dependent upon where you are from the point of view of age. During infancy, the parent or the guardian is making the decision for the infant. And you need to think about things such as genetics. What is the specific mutation that the infant has? And family history of inhibitors. Is this child at a higher risk for developing an inhibitor because we know that it runs in the family? And ethnicity. We do know that certain ethnic groups have a higher incidence of inhibitor development, as well as severity. There are some infants that bleed from the get-go. We generally think about the first 6 months of life as being a honeymoon period because infants are pretty much just eating, peeing, pooping, and sleeping. They're not doing a lot. And once they start to be more active, they begin to roll, they begin to crawl, they begin to cruise, they begin to climb, you begin to see more bleeding. But we know that that's not true for everyone. Some infants have a very difficult delivery and have bleeds. Some infants have spontaneous head bleeds. Some infants begin bleeding into soft tissues right from the get-go. And the choice there is a little bit different than for an infant that's having no issues. And access. Access is a problem for infants. Peripheral access, small veins in small children can be quite difficult in terms of infusing factor. And central access sometimes have to be considered very early on in terms of using an infusoport or Broviac. In childhood and adolescence, again, inhibitors or histories inhibitors are going to impact in terms of what you choose to use. How active is the individual? Do they participate in 2, 3, 4 sports? And what is the frequency of their bleeds? Because that will determine how frequently they need to be covered. And what are their individual pharmacokinetics? No two people are alike in terms of how they respond to and metabolize the product that they're using. Again, access plays a role. Some people have great peripheral access and some don't. And the use of central venous lines sometimes needs to continue through childhood and occasionally into early adolescence. And lastly, young adults and adults. Again, taking into account inhibitor history, bleeding history, activity, many people become less active as they get older. Some people don't, and they continue to do the same kinds of crazy things they were doing when they were 16. But that plays a role in terms of what their bleeding is going to be like. Individual pharmacokinetics again, satisfaction with your present regimen. If you like your present regimen, there's not necessarily a need to change. On the other hand, if you're not happy with it, you need to explore other options. And lastly, as a young adult or an adult, you do have the option to participate in clinical trials. Clinical trials are usually geared for young adults and adults because they are able to give consent. They're able to say, yes, I understand the risks and the benefits, and I'm willing to take those risks to possibly achieve the benefits. We generally don't start new products in a newborn infant. We do usually do it in older individuals and then backtrack into younger children. And I encourage people to participate in clinical trials if they are so inclined. So again, what I want to emphasize is that no one treatment fits everyone. You're different. Everybody is an individual. And you need to educate yourself with regards to what's out there. And that can be done through a variety of ways. Talking with your hemophilia providers, attending educational sessions, talking with family and friends. Discussion with your hemophilia staff will lead to your ability to make decisions. And I do emphasize the acknowledgement of the fact that benefits and risks change over time. We know that. We learned that the hard way back in the 70s when we found that there was a significant downside to the plasma-derived concentrates because of viral contamination. But nobody knew that in 1970, that was going to happen in 1980. So you need to at least acknowledge the fact that this can happen. And you also need to acknowledge the fact that your own needs change with time. So I want to emphasize the fact that treatment choice should be a joint decision between you and your providers. In summary, we've gone from the 2nd century to the 21st century, and over that expanse of time, we've recognized the existence of a bleeding disorder. We've identified the need for prevention of bleeding. We've discovered the genetics of these disorders. We've determined the role that factor VIII and IX play in coagulation. We've developed progress in treatment with huge developments in the last 20 years. There's been the development of non-factor therapies and more on the horizon. And we need to, again, identify, recognize the role of parental and patient voice and choice. So I want to thank you all for attending, and I hopefully can answer whatever questions you might have.
Well, Cathy, I think I could speak for all of us. We could listen to you for hours.
I don't think so.
That was not an easy.
My family can attest to that. No, you can't.
But that was not an easy feat to go through the history and where we are today. And I think this slide here summarizes so many changes that have happened over the past several years and where we're going into this community. Is if we use this as a roadmap, we will be informed patients to navigate all of this to come. So with that said, I know that Brandon and Sarah, if you guys can wave, I need to give them a shout out who are on here tonight, our small and mighty staff that has really helped to pull this event together. I'm monitoring the chat. And we're going to do some rapid fire questions with Cathy. So Cathy's up to bat, and I'm going to be the pitcher. And I'm going to throw some questions virtually over to Cathy. So the first question that came in is about gene therapy. There were recently 2 children with a rare neuromuscular disease that died after receiving a high dose of a gene therapy in a clinical trial run. How will this affect gene therapy specifically for hemophilia?
It's a very good question. We learn a lot from gene therapy trials, no matter what they're being used to treat, no matter what the disorder is. But they don't always cross over necessarily to different disorders. That particular trial with those 2 children were using very large viral loads, very large increasing loads of the genome. And they were doing that specifically because of the way this disorder works. So we are not necessarily doing that exact type of delivery with hemophilia, number 1. Number 2, those individual patients had liver disease to begin with, and they died of progressive liver disease and then infection. So again, severe liver disease might preclude you from the gene therapy trials to begin with for hemophilia, the way they're set up right now. So again, what happened in that particular trial doesn't necessarily cross over to the hemophilia trials. Certainly we pay attention to these things and try to avoid making the same kinds of decisions, but I don't think it's going to directly affect the hemophilia gene trials.
Great, thank you, Cathy. If you can go back to your previous slide, I think that's a good landing slide for all of us to see as you answer these questions. Yep, perfect.
Is that good?
Yeah, yep. If you go present from currents, actually, you know what? That's fine.
It just, I don't know why it.
Yeah, you could just leave
okay,
it.
there we go.
Leave that. We could see it. I think, yep, perfect. There we go.
Okay.
You're a technology whiz. We're going to give you a doctorate in Zoom by the end of this.
And you know that is not true.
We'll walk across the virtual stage soon. The next question that came in is, do you feel that factor VIII protein will ever be able to have an extended half-life close to factor IX? Why or why not?
I did touch on that a little bit. The difference between factor VIII and factor IX is that factor VIII is stabilized by a carrier protein, the von Willebrand's protein. They travel together in the plasma. And therefore, the metabolism, the half-life of factor VIII is also dependent upon the half-life of the von Willebrand's protein, which is only about 15 hours. So in order to achieve a longer half-life for factor VIII, we have to somehow modify that von Willebrand's protein as well. And that would rely on either making the von Willebrand's protein last longer or somehow disassociating it from the factor VIII so that it doesn't impact on the half-life of factor VIII. People are working on that. They're trying to find ways to allow that to happen so that we can have better extended half-lives for factor VIII, but they're not there yet.
Great, thank you. So we're trying to categorize these questions. We may jump around a little bit, but we're going to move to the non-factor therapies. A couple of questions came in about that. Is there a recommendation to introducing the use of factor to pups starting on Hemlibra? So recommendation of introducing factor to a pup starting on Hemlibra.
So Hemlibra is still very new. It's been around for about almost 2 years. I mean, in terms of clinical practice, it's very new. And therefore, unlike many of the other products we use, there aren't recognized guidelines for how to do this. Most people develop their own expertise or experience, and I think if you lined up 10 different hemophilia providers, you might get 10 different answers to that question. So we know that with Hemlibra, and there are centers that are starting Hemlibra almost at the time of birth. But we know that if you have a breakthrough bleed, you have to use factor. It doesn't help with breakthrough bleeding. So you would have to, at that time, give the child a factor VIII product. But I don't know that anybody's actually independently or separately introducing factor VIII without a reason to give it, if they've started a child on Hemlibra. And then there are other reasons for starting Hemlibra. I mean, clearly there are infants who do have bleeding right from the get-go. And again, because of access issues, Hemlibra might be a choice for trying to prevent them from having ongoing bleeding, even in the first second month of life, as opposed to using factor VIII prophylaxis.
Great, thank you. The next question is about Hemlibra as well. Does the use of Hemlibra increase the risk of clotting? Is part one of the question. And I'll read the next part after you answer that.
So Hemlibra is intended to increase clotting. It's intended to get the blood to clot on almost on a steady basis. It's trying to mimic what people who don't have factor VIII deficiency do on a regular basis. Their blood clots. Is there a risk for pathologic clotting, thrombosis? Yes, there is. It appears to be primarily seen when you're using additional products to achieve hemostasis. So not just the Hemlibra by itself, but Hemlibra with FIBA or Hemlibra with activated recombinant factor VII. And that seems to be the tip-off in terms of the potential for extra clotting, as opposed to just using the Hemlibra.
Great. The second part of this question is, if you have factor V Leiden plus factor VIII deficiency, or having factor VIII deficiency plus a history of other clots, DVTs, would that patient be at a higher risk of developing clots by using Hemlibra?
Who asked that question? Holy smokes. Wow, this is a tough audience. So factor V Leiden is one of those, we talked about balance and how typically you're in balance. You've got enough proteins to prevent you from bleeding, enough proteins to prevent you from clotting too much. Factor V Leiden is one of those inherited prothrombotic disorders. It's the most common inherited prothrombotic disorder, and it's also one of the more mild inherited prothrombotic disorders. Having said that, do you clot? Yes, there are people who clot with factor V Leiden. And therefore, if you now give them another product that's going to increase your risk for clotting, theoretically, you could say, yes, you're going to increase that individual's risk for clotting. On the other hand, you could potentially say, well, by giving the Hemlibra, you've now induced a state that's more similar to what most individuals are who also have factor V Leiden. You've eliminated that factor VIII deficiency component because you are inducing a more steady state of hemostasis. And so maybe now what you've done is actually just make this person more like an average individual who has just factor V Leiden and not a concomitant factor VIII deficiency. The bottom line is, I don't actually know the answer to that question because we don't have enough individuals who have both of those coagulation abnormalities and is on Hemlibra. And that's one of those situations that I think is going to remain to be seen as we go forward with increased use of Hemlibra.
Thank you. A couple of more balls being tossed this way. Is it more of a risk to prescribe Hemlibra in pediatrics versus prescribing clotting factor?
There were I don't think that there's more of a risk to a child using Hemlibra versus using a coagulation product. I think that I don't think that the risk is any greater for a 10-year-old versus a 20-year-old. I'm not sure what the question is. If it's asking the use in pediatrics versus adults.
Yeah, I think
Or,
that is it more risky for pediatrics to go on Hemlibra or
yeah,
on clotting factor?
they certainly they've used Hemlibra in children in one of the clinical trials. It appeared to be safe. It's been used in children with inhibitors and factor VIII deficiency, and it absolutely appears to be safe. Is there a potential risk? I can't say it's zero, but I don't think that there's enough of a downside to not use it.
Thank you. This question came in and it states, I'm going to summarize here. Every time I go to my comp clinic, I feel pressured from my provider, the hematologist, and the nurse to switch. I am not ready to switch because I have reservations about these new treatments, and I'm happy on the current treatment that I'm on. Can you give me any advice on how I could have a better relationship with my provider so that they actually listen to me?
You can come see me. No, I'm kidding. I'm kidding. You know, that is a difficult situation for the individual to be in, and it actually makes me somewhat disappointed that he feels that he's in that situation. Um, I think our role as providers is to provide information, is to work through the problem of choice with the individual, and to jointly come to a decision. I would agree with you that if you feel comfortable with the product that you're using, you feel comfortable with how it's working in terms of breakthrough bleeds, maintaining your ability to participate in activities, your access is okay. I mean, basically you're satisfied with your regimen, then there isn't necessarily a reason to switch. I think you can very firmly but politely say to your providers, I appreciate your expertise. I appreciate the information that you're giving me, but I want you to realize that I'm doing okay. And I like the product that I'm using. And for the time being, I want to stick with this. Maybe I'll change my mind in a year. Maybe I won't. But for right now, I'm happy. And I think that as long as you do that in a calm and but firm way, that they should be respectful of your choice.
Great advice there. Thank you, Cathy. The next question that came in states, is tolerizing factor VIII while using Hemlibra a treatment option that is being considered across the board by our health professionals? Will it become a treatment option, and what is the goal? A standard treatment option, and what is the goal?
It is, people are doing that, and they are looking at that. There isn't a huge study looking at that, but the concept of trying to maintain adequate hemostasis with the Hemlibra while you're still trying to tolerize the individual so that they can use factor VIII if they need it, is certainly an option. And there are people who are doing that.
Great.
Again, I want to emphasize that you have to be followed closely by your provider, because you are getting, if you're on an immune tolerance regimen, high doses of factor VIII along the way. So you want to be sure to be monitored for any potential development of a thrombosis, but it is being done.
Great. Thank you. There have been a couple of questions about VWD coming in. I'm going to put a plug for Dr. Eric Parnes for next week at this time. He is going to be talking specifically about VWD and other rare bleeding disorders. So if you asked any VWD or other rare bleeding disorder questions, we're going to save those for Dr. Parnes for next Wednesday night. And in the chat is the link to register for that. It will be recorded as well, so you can listen to it. But we want to stick tonight, since we're already over the 8 o'clock hour, to the hemophilia questions. So there's a couple of questions that came in that are COVID related. The question is, there is so much new information about clotting in COVID. What does this mean for those with hemophilia and other bleeding disorders?
I'm going to preface this with saying I'm not a COVID expert, but it's interesting. I participated in a webinar, I listened to a webinar of various people involved in treating patients with COVID. And they were both pediatric and adult treaters. And I asked the question, what are you seeing with regards to your patients with hemophilia or bleeding disorders and those who have had COVID? And at that point in time, nobody had seen anybody with a bleeding disorder and COVID. And that was about a month ago. But the point, there are a couple of points to be made. Just because you have a bleeding disorder doesn't necessarily put you at a higher risk for contracting or developing COVID-19. Now, if you happen to have a bleeding disorder and a comorbidity, you have diabetes and hypertension and you're overweight and you're older and you have asthma, that's different. Or you're on immunosuppression, that's different. Those comorbidities put you at higher risk for contracting coronavirus. If you don't have any of those things, but you do get coronavirus and you have a bleeding disorder, the risk is actually for excessive clotting. The problem that we've run into has been a coagulopathy, but excessive clotting, so pulmonary emboli and stroke. And therefore, we would have to carefully watch, because we would not want to stop your replacement therapy in any way, but you'd have to be monitored really closely to make sure that you didn't, for any reason, develop any of those problems that we see with anybody else. And I certainly wouldn't want to stop your factor during a time of significant illness, because one of the problems with COVID is respiratory, and certainly with pneumonia and difficulty breathing and excessive coughing, you could have bleeding associated with that if we were to stop your ongoing factor replacement. So it's an interesting question. Clearly, you would have to be watched very closely, but fortunately, it hasn't been a huge issue as yet.
Great, thank you. There's about 3 different questions that came in. I'm going to combine them all into one, and it kind of combines COVID and gene therapy. So the question is that with the timeline of potential gene therapy maybe coming out this year, has COVID delayed the development of any treatments like a gene therapy from actually happening? So is COVID delaying the FDA from approving or considering the approval of a gene therapy or maybe a new potential treatment for hemophilia?
So COVID, I don't think that COVID is going to affect the FDA's timing of its decision, because that information is already there for them to be reviewing and exploring and making a decision. We have had some delays in clinical trials starting because of COVID. I mean, I know even here for a different disorder, we were going to start a gene therapy trial, and we had to put it on hold because the company did not want to embark on this particular therapy in the midst of this pandemic. So from that perspective, it might delay the start of trials, but anything that has been ongoing should continue.
Thank you. Good information there. I'm going to pivot back to gene therapy since we're on the gene therapy train now. And I'm probably not going to pronounce this correctly, so I apologize in advance. And I may need your help, Cathy, for some of these words here. Does the product that utilizes the adenovirus as a delivery vector come with an increased risk of adenocraninotomy? Did I say that right? Probably not.
I don't know what adenocraninotomy
Maybe Sarah or Brandon, if you want to take a stab at saying that.
Adenocarcinoma.
Thank you.
Adenocarcinoma.
This is a
Well,
test.
you really butchered that word.
No, I should do charades and kind of just acted it out to see if you can get there. Thank you, Brandon.
Okay, adenocarcinoma. Okay, so no, it's completely separate. So adenoviral vectors and adeno-assisted viral vectors actually refers to a very specific virus, adenovirus, and that's not connected to adenocarcinoma. So no, there isn't an increased risk for adenocarcinoma associated with the AAV vector that they're using to put the gene in to do the gene therapy. And in addition, what I thought the person was going to ask is there an increased risk for infection associated with this? And even that, before they insert the gene into the viral capsid, they have actually taken out the guts of the virus so that the virus itself can't replicate. What's going to replicate will be the genome for the factor 8 or the factor 9. And they worked that through because they were, in the original clinical gene therapy trials back in the 90s, quite concerned about infection associated with the viral vectors that they were using.
Great, thank you. And I just, if I'm on Jeopardy and that's the question, don't ask me because I need to call, I need to phone a friend there. This one came in that is a great, whoever did ask this, we're going to put a plug for the live session on July 25th because we have NHF and we have several others, HFA and some of our industry partners that are going to be specifically talking about the cost of gene therapy, of what this looks like. But you know, Cathy, if I could put it to you as a provider, I know you're not the insurance expert, but as the provider, the question is, how is the issue of cost going to be considered in gene therapy approval? I've heard that a treatment can cost $1-2+ million. And you know, the comment goes on to say BioMarin has reported a waning of effectiveness possible, you know, to another course. Could this really be approved by payers to replace something like Hemlibra that is much more affordable? And I think before you enter that, this is also a plug on Saturday, July 25th. You will have access to all these companies like BioMarin, and that's a great time to ask them specifically as well. But Cathy, I'll see if you have any insight to this.
I wish I had better insight to this because these are the same questions that we're asking. Here at the hospital, I was just talking with our pharmacist today because we have been exploring the possibility of providing gene therapy if and when it becomes available as a potential site. But in looking at what the cost is for some other gene therapies that are already out there, you are looking at, I don't know, $2, $3, $4 million for one infusion. And you're absolutely right. If it wanes in terms of its efficacy, and then you're looking down the road at doing it again, will insurance cover this? I don't have the answer to that. I know that when recombinant factors came out, we had a really hard time. This is back in the early 90s, and we had a very hard time getting the insurance companies to approve switching from plasma-derived to recombinant. And we were talking about 25 cents a unit to compared to $2 a unit, I mean, which compared to gene therapy is trivial now, but at the time, insurance companies were saying, we're not going to pay for that, but they eventually did. And so I think what's going to play a crucial role in this is going to be the cost analysis over the lifetime of an individual at the point that they get their gene therapy. What is that going to look like in terms of the fact that they are not going to be continuing to use their products? And that it's going to require that kind of financial analysis in order to, I think, convince insurance companies that this is going to be worth the price. I do also think it's going to depend upon what price tag the company puts on the gene therapy. And they're going to have to take that into consideration, or nobody's going to sign up for it. So I don't know the exact answer to that, but it's something that we're all talking about.
In the interest of time, we have 2 more questions. Cathy, you're a trooper, you're still at work. Thank you for doing this. We appreciate it. But that is a nice setup of how many people do you expect if gene therapy hit the market? Is it the entire hemophilia A population that has access? What is the pool that is the estimate if it were to hit the market of people that have access to this?
So I would expect that there will be very specific criteria that will come with the gene therapy, that they will, that the FDA will say it will be initially approved for people of a certain age or people with very specific complications, or you may not be able to access gene therapy if you have specific complications. One of the things that they were looking at is people who already have antibodies to the viral vector. If you have a high titer of antibodies to the adenovirus that they use, they worry that it's not going to work, that your immune system will destroy the vector. So I think that I think initially it's not going to be available for everybody, and that's going to evolve with time.
Great. Last question here. It's about fitusiran. How do you balance excessive clotting with this potential medication? Is it just about the dose, or are there other considerations?
I'm going to be honest in saying I don't know exactly how we're going to balance that. I don't know. And it's one of my concerns in terms of how this product works and how well it and how you use it. It's still in clinical trials. It's not obviously out there just yet. I suspect it has to do with how much is being used in terms of trying to create that balance. But I don't have a good answer for that.
Well, thank you, Cathy. You have done an incredible job, and I hope you look at the chat. You have a lot of fans out there that are giving you quite a bit of accolades from everything. Excellent presentation. Thank you. So great to hear you talk. Thank you. You are the very best. This is a great presentation. Lots of thank yous here. This is a quote. One of the best presentations I've seen. I'm fascinated by the early history. You should present nationally. This was fantastic.
I paid that person to say that.
Yeah, I did. I gave him one of my mom's cannolis. A couple of other things that in the chat for those that are out there, there was a comment about the individual that felt that their provider was pushing them to a product, and someone had said, well said, our product works perfectly for our boys, but we are excited for all these new treatments on the horizon. So just echoing kind of your sentiments. And then someone else did post that there's a clinical study right now out of Emory under Dr. Sidonio and Meeks that's using a combination of Hemlibra and plasma-derived products for hemophilia A patients with inhibitors. As you said, there's a lot of trials going on. So there's a link to the clinical trial that you can check out and see, which is great. But with that said, Cathy, thank you. Thank you, Dr. Rosenfield, for spending your night with us. This was absolutely fantastic. A recording will be live on the NEHA website and on YouTube. And I also just want to give a plug to what's next. Thank you for staying with us and imagining what a virtual consumer medical symposium would look like. If you've attended other events, this is going to look very different. We did not want you to sit in front of a computer for 8 hours on a Saturday in the summer. So we're trying something really unique and outside the box, where it's a Wednesday night, an hour and a half, followed by a live session on Saturday morning. And then we have an exhibit hall that will be open that you can do on your own. And then a scavenger hunt. For those that were with NEHA for Family Camp, we use this awesome interactive experiential app called Goose Chase. So you'll be able to answer trivia questions about tonight's talk and get points for it. And anyone over a certain number of points will get an Amazon gift card. So our intent is everyone gets an Amazon gift card, because you're going to answer these points and you're going to remember some of the things that were said tonight. So Brandon has put, and Sarah, the event links in the chat, but Dr. Parnes is ready to go for VWD and other bleeding disorders next week. But with that said, we really appreciate you being part of our Wicked Strong family, for believing in NEHA through all of this craziness and for staying healthy. And again, Cathy, thank you for the work you did on this presentation and for spending your evening with us.
Thank you.
Great. Have a good night, everyone. Hopefully we'll see you next weekend. Next week, not next weekend. There's nothing going on next weekend. Good night.
Good night.